Hey everyone, I think we should get started. Welcome again to Andy, and she's going to be running the show today. So a reminder not to disclose any private health information during your case studies. Here's the usual information about assistance, the usual information about cardio, and this is our team, of course, and these are our participating sites. And I will be presenting today. I'll be discussing things with Jim Werner as well. I believe Adam Przinski was supposed to be one of our discussants today. He is unavailable. He's out of town. And we'll have cases from Sarah and Holly. Disclosure statements are shown here. Nothing new that I can recall. And we're going to start with our topic this morning. The full disclosure, I'm not an expert in this area, but we pretty much have the world's leading expert, Dr. Sanjay Rajgopalan, here in Cleveland at UH, and he's both a friend and a colleague of mine. And some of you know Ian Neeland as well, who is one of his mentees, who is also very, very interested in this area. So everything I know, I've learned from both of those two individuals, and they've written some landmark articles in the New England Journal, et cetera, that I referred to in preparing for this presentation. So the goals for this very brief talk are to list a minimum of 3 environmental pollutants responsible for increased cardiovascular risk. Describe disparities in exposure to these pollutants among different racial and ethnic groups, and a minimum of 2 resources to identify communities prone to increased cardiovascular risk due to environmental pollutants. So I think, I can't ask for a show of hands, but how many of you remember this scene from a few months ago? It wasn't that long. I think it was June or so. And this is actually New York City, which was very badly affected by wildfires in northern Ontario and northern Quebec, in areas that are so vast and so inaccessible, there's no way to actually put out the fires. And of course, that's a function of climate change. And the warnings that we got, I think a lot of people took them. It's interesting how much attention we paid to COVID-19, and people were very vigilant about it. But this is actually every bit as dangerous. So a lot of these small carbon particles that floated down towards the northeastern United States and the Midwest are extremely dangerous. So I can remember, I think it was one of my daughter's sports events or something like that. And it was recommended that people wear masks, but then nobody did. Nobody took it seriously. And the kids were out there for a short period of time. That sort of thing was going on quite a bit, and people were exercising still outdoors. So it's interesting to me that we don't pay a lot of attention to air pollution in particular. So air pollution is the primary type of pollutant to be considered when it comes to cardiovascular risk. Of course, there are elements in the water supply that we might think about. Of course, there are toxic chemicals that can raise your cardiovascular risk, but overwhelmingly, we all must breathe air, just like we all must eat, right? And therefore, this is what we're concerned about. And you'll hear the term PM 2.5 quite often. It refers to particulate matter 2.5 micrometers in diameter or smaller. And among that category, the main things to be concerned about are sulfates, which are emitted by plants for the most part, and organic carbon, of course, which comes from burning wood, coal, etc. To give you an idea of how small this is, a human hair is roughly 50 to 70 micrometers in diameter. And a PM 2.5 is, 20 times or more smaller than that. Dust, pollen, mold, things that you can possibly see if you look carefully, are about 10 micrometers. And one tiny grain of sand is almost 100 micrometers. So this is really, really small. It's not really visible. And you can imagine we breathe these in, and they can cause significant damage over the course of time. So in terms of why this is important, number one, it is undisputably linked to cardiovascular morbidity and mortality. There's a mountain of evidence suggesting this. So the estimates are that 4.2 million people died just in 2015, and that the number of disability-adjusted life years lost in that 1 year was 103.1 million across the world, representing 7.6% of global mortality due to PM 2.5, 4.2% of all the quality years lost. So this DALY stands for disability-adjusted life years. So the number of deaths attributed to this ambient air pollution alone, just air pollution, is more than heart disease, stroke, COPD, lung cancer, and lower respiratory tract infections, including COVID-19, all put together. So astronomically high. Next slide. And it is dose dependent, of course. So the more polluted your air is, the more likely you are to have ischemic heart disease mortality. So it is comparable, for example, to cigarette smoke. The higher the dose is, then the more likely you are to get to have a mortality effect as well. And it is not just related to heart disease, but also to stroke, as you'll see in the bottom right corner. Next slide. So the mechanisms are really unclear, but we know that when you breathe something in that's not supposed to be there, we know this, for example, from people who were first responders during 9/11, who rushed to the scene and often without masks on, that those particles are inhaled and they cause systemic inflammation. And of course, that inflammation, which you see in the middle part of this particular circle, can raise cardiovascular risk through endothelial damage, plaque, thrombosis, etc. The typical mechanisms that we see for increased cardiovascular risk. There's also a very interesting phenomenon called the harvesting effect. And that means that, well, maybe all this air pollution is not causing a lot of mortality. It's just that people who are prone to mortality from heart disease are actually, their mortality is being displaced forward because of air pollution. In other words, let's say we have a period of especially poor air quality. And here in North America, our air quality is actually pretty good, but China and India are the two prime examples where air quality deteriorates significantly over time. Heart disease mortality goes up over that short period of time, but those people likely would have died anyway at some point within the next 6 or 12 months or so. So perhaps it's not doing that, but nevertheless, this is a huge problem. Next slide. So the consequences are, I was blown away by some of these statistics. Each 5 microgram per meter increase in PM 2.5, and then you know this is typical, is associated with increased coronary calcium, which in turn is associated with ischemic heart disease. This is the interesting thing. Short-term increases upon exposure. If you have a situation in large Chinese cities, they sell a lot of these room air filters, your actual blood pressure goes down over the course of a few hours just by turning the air filter on, which I think was amazing when you think about it. Acute coronary syndrome, with every 10 microgram increase, you get a 2.5% relative increase in MI. And of course, it's related to many, many other aspects of cardiovascular disease, arrhythmias, heart failure, peripheral vascular disease, venous thromboembolism, and diabetes and stroke. Next slide. So what do we do about this? Well, we can wait and see how society as a whole is going to respond. That does not seem like a very promising strategy. Air travels all over the world. When you think about the fact that you have 2 gigantic countries that are growing rapidly and emitting more carbon, despite whatever their efforts have to be, that air is going to affect everyone in the world. So governmental reform, of course, involves vehicle emissions, which is important. Reforestation, just planting trees. And there was an interesting study that if you're a jogger and you run through an area where there are lots of trees, like in a park, Central Park, I think in New York was the example, you will have a lower blood pressure during that time, simply because the trees are absorbing so many of these 2.5 micrometer particles. But I think here's the most important thing. I mean, decarbonization, getting to net zero, is often cast as a strategy for climate change, which of course is extremely important. But in addition to that, it can, a complementary benefit is it's a health strategy, and that may be more convincing for some people. If you're not convinced enough that climate change poses a great threat, then you can think about it, well, what about just air pollution and the effect it has, especially on young people and the elderly as well. Next slide. So here are things that I think everyone should do, and this comes from recommendations from Dr. Raj Gopal and others. First of all, you can monitor air quality And there's a website that most of you may know about, Air Now, and you just check out it. It'll map your location and give you some idea of the air quality. You know, our patients, even elderly patients, and 95%, I believe, have smartphones and use them for various purposes. Certainly to check the weather forecast, to check emails, texts, etc. On days which are especially where was an air quality alert, all they have to do is go on this website and see if the air quality is good or not. And if it's good, of course, they can carry on with their usual activities. If it's poor, I would not recommend spending any time outdoors. Next slide. The other thing is people can buy these air filters. I looked on Amazon at what the price range is. I wouldn't recommend buying one for $18.95 or something. I don't know. There's certain approvals that seem to be missing at that price range. But once you get to about $50, you get some air filters that are approved, that are known to filter out the 2.5 micrometer particles. And that's enough to mitigate cardiovascular risk. So the picture I can see is we have patients, which Sarah and Holly might present today. These are middle-aged people with multiple cardiovascular risks. And we have an air quality alert day. They check the air now, they purchase one of these filters, and that's about all that we can do on an individual level. No, they are not covered by Medicare, but they are $30, $40, $50 or so. I think it's a worthwhile investment for many people. Next slide. So here is something else I wanted to point out that I think is very important. There's no point in monitoring your air quality or buying an air filter if you're a smoker. As bad as the air might be, on a really bad day, or in Beijing, China, for example, it's nothing compared to puffing a cigarette into your mouth. It's not even close to that. And the interesting thing is, if you look at who smokes, the overwhelming risk factor for smoking is low income. It's one of those contradictory things. The poorer you are, the more you spend on cigarettes, just like fast food, for example. There are some modest racial differences. I don't consider these to be hugely significant. American Indian Alaskan Natives are perhaps the heaviest smokers. We don't have a significant population here in our state. But white and Black Americans are heavy smokers when they are below the poverty line. Women slightly lower, but not that different really compared to men. And you think about if they're above the poverty line, if you look, for example, here at this line, only 15.8% of non-Hispanic Black women who are above the poverty line are smokers. And you compare that to some of these other groups, white men, for example, below the poverty line, it's not even a third of that level. So income is the number one risk factor. The cost, I calculated a pack per day. Many of my patients smoke more than that. Some smoke less, of course. It's $2,416 annually. When you think about what the poverty line might be for an individual, I don't know what it is. It may be in the high 20s or something like that. That could represent up to 10% of someone's income being spent on a product that is devastating for their health. So smoking cessation, it's the old story. You have somebody who is morbidly obese, smokes, has hypertension, diabetes, and comes in to see me and says, should I be taking a vitamin a day to maintain my health? You can take a vitamin a day. You can buy an air filter, but smoking cessation should be the priority. Next slide. So the poor also suffer disproportionately. So poor people smoke much more than people who are above the poverty line, but they also suffer disproportionately from exposure to PM 2.5. And the reasons for this, as you can probably tell, are probably geographic. So poorer communities are closer to polluting sources, for example, coal-fired power plants. They may be downwind. They may just be located in areas where pollution tends to accumulate. And so there are some disparities here as well as when it comes to exposure to this sort of thing. And if, of course, if you're above the poverty line, you have less exposure because you could live in neighborhoods that are less likely to be close to those sources. Next slide. So here are the key lessons. Number one, PM 2.5 is a major cause of cardiovascular morbidity and mortality. Now, among the two culprits, it's carbon and sulfates. Ozone is another major gaseous pollutant which adversely affects cardiovascular health. Of course, you know, in the greater Los Angeles area, you have an inversion effect, and smog is a major problem. Less so here. Avoiding polluting environments and circumstances is especially important for patients with cardiovascular risk factors or cardiovascular disease. It's not that hard. You know, if you must go out on days when there is poor air quality, wear a PM95 mask, for example, or just don't go out. And when you're indoors, because a lot of these particles will be on clothes, et cetera, and will make it indoors, use an air filter. So this is what I would recommend for all older patients with cardiovascular and respiratory illness. Use masks, monitor air quality, and exercise indoors when outdoor air quality is poor. It's all very, very simple. This will mitigate your cardiovascular risk by a significant degree. So let me stop there and see if there are any questions, and I will do my best to answer them, and I'll filter my my colleagues in cardiology who supply most of this information. Any questions? Gary, go ahead.
Dr. Rao, what type of mask should those patients have?
Yeah, it should be the N95 masks, Gary.
Okay. Yep.
It's the same mask that one would use to avoid COVID-19. I'm sorry, Austin. Yeah, Austin, do you have a question?
So I apologize if I missed this, but once you buy the filter, are you vacuuming them out or washing them? Do you have to buy repeat filters to filter? How's that work?
Yeah, it's quite variable, Austin. I know that the better ones, you just wash them out periodically. You don't have to keep buying. It's not like a furnace or a vacuum cleaner, for example. So there's not a lot of ongoing cost to it.
Okay, great.
Dr. Rao, this is Paul.
Yeah.
Quickly, fascinating. One of the elephants in the room is smoking, and we're all familiar with programs, some more successful than others. In your experience, has one program been more successful than the other? What do you recommend that your patients do?
That's a good question. I'm glad Jim is on with me. So I'm a practicing primary care physician. I follow the basic 5 A's paradigm for smoking cessation: ask, advise, agree, arrange follow-up, etc. And I give them a little slip that you see the Ohio quit line. And I actually listened in once, Paul, because one of the patients decided to call the quit line, and they were remarkably helpful and supportive. So it's just a matter of getting them to that point, which I will confess I have had a very hard time doing. I don't know if people have had the same experience, but so smoking is the elephant in the room. It overwhelms all of this stuff. All of this stuff is just window dressing, and we've got to address smoking cessation. So let me see, Jim, if you had any other thoughts on what you found especially helpful as a strategy.
Yeah, Goutham, the 5 A's have been shown to be, evidence-based practice, and they're relatively easy to use as long as you do have some resources that you can refer patients to locally. And really, in Ohio, as you said, the Ohio Quit Line, which is now a national quit line program through, I believe, National Jewish in Denver, is really excellent, and they have really good outcomes, and they are very supportive. I've talked with them before about coverage issues, and they said that they can work with patients, and whether they have private insurance, Medicare, whatever their insurance situation may be, they can usually find a way to cover almost anybody, really anybody, for the Ohio Quit Line coverage. So it's a very good resource. It's very simple to use for a physician or a clinician to refer patients to. So I highly recommend that.
Thank you. So we would like to invite everyone to our Cardio Fall 2023 webinar, Heart Failure Risk Management, What to Know, What to Do. It's October 25th, and you can register on Cardio's website or using the QR code. Next slide. Just a reminder that you can see all past echo clinics as well as this session online using these different links. Next slide. And then just some reminders, you should have received the post-clinic survey in your inbox around 8:45. Let me know if you didn't receive it. Please complete that by tomorrow at 5 p.m. I did attach the case study presentation schedule to the email I sent yesterday. We are still missing some cases. If you can get those to me as quickly as possible so we can send a final list, that would be wonderful. And then any other questions, feel free to email me. And those are all my updates.
Thank you, Andy. So just a plug, and Claire reminded me to remind people about case studies yesterday. So case studies are the essence, they're the core of ECHO. So the didactic lecture at the beginning is almost intended to prime people for a case-based discussion, to get you in the mood, so to speak. So we really rely upon case studies from all of you. And of course, we could recycle old cases. I could recycle old cases, but I really prefer if people thought carefully about a patient they've seen over the last few weeks that might be appropriate for discussion, especially because our theme is health equity and cardiovascular risk. We focus upon underserved urban patients as well as rural patients, patients with diabetes. The two cases today were excellent. Obviously, I thought we had a great discussion. So please, don't worry about whether your case is absolutely perfect or you solved all the patient's problems. That's not what this is about. It's to stimulate an interesting discussion, which we had this morning. So please email those cases on to Andy as soon as you can. Okay. Thank you very much. We're at 8:59, 30 seconds. So have a wonderful rest of your day. Take